Welcome back to The Wellness Effect. To catch up on any of our discussions with full-length episodes, subscribe. In this episode of the show, we look at the current state of the HIV and AIDS epidemic in South Africa. This will be a first in a series focusing on how this issue affects the nation. Shedding light on the topic today is Professor Theresa Rossouw from the Department of Immunology at the University of Pretoria. Welcome, Professor Rossouw.
Thank you so much, Seth.
It's a pleasure to have you, and I'm really looking forward to this conversation.
Me too. Thank you.
So, Professor, why are we the most affected nation when it pertains to HIV and AIDS?
No, Seth, that's a very complex question, but let me try to break it down. One of the biggest problems is that we started treatment very late. So you will remember in the old days, there was a lot of discussion about antiretroviral therapy, and we actually delayed the implementation for many, many years. And that allowed the epidemic to spiral out of control. And then when you have such a big pool of people who are infected, you don't need to have very high-risk behavior to become infected yourself. So that was definitely one of the reasons.
Sure.
Additionally, we have lots of cultural and gender norms that add to this propensity to become infected. One of them being high levels of gender-based violence.
Sure.
Up to 30% of women reported a recent incident of gender-based violence. And that fuels the pandemic because there's no prevention, there's a very high-risk exposure. Also, we have this phenomenon of blessers.
Yes,
where, yes. So it's the younger women
Correct.
and the adolescent girls who have a boyfriend who's much older, usually about 8 to 10 years older than they are, who then, bestow them gifts and even money or food. And these young girls are then not able to negotiate safe sex.
Correct.
So very low condom use, and that exposes them to risk. The last factor that I would name is also a very high prevalence of sexually transmitted infections. So in recent data, they've shown that young women, so we're looking at the ages of between 15 and about 30, about 30% of those young women have at least one sexually transmitted infection. And here we're looking at things like gonorrhea, syphilis, trichomonas, chlamydia. A lot of those can be asymptomatic. But when you have that infection as well, it increases your risk of acquiring HIV. Now, in women, that's about double the risk than we have in young men. So in young men, it's about 17%. So we see in South Africa as well that the young women are really disproportionately affected, not by STIs only, but also by HIV.
Yeah, I was going to ask, my next question was at who's at risk, but I think you've covered that, and it's looking like it's young women. Would you say it's young men who are in a vulnerable place, looking for opportunities, or are found in poverty-stricken environments that are at the greatest at risk?
Absolutely. So we do see that. It is a way for people to get an income. So poverty definitely does play a role. But we also see it in contexts where there are multiple sexual partners. We know a lot of these older men also have another older women together with the younger women, and that concurrency also increases risk, as you can imagine.
Yeah.
We also know that there are other at-risk groups, sex workers, for instance. They are, of course, very vulnerable. Once again, low condom use, lots of STIs, very little agency to negotiate, once again, for safe sex. So we see very high rates of HIV in sex workers. Another group that is quite vulnerable is men who have sex with men. Just because anal transmission is much easier with HIV, it's also something that's still very stigmatized. So people don't, really talk about it. They don't go to a healthcare center and ask for the help that they need. So those, we call them the sort of the key populations. Those are also groups that we need to consider.
You mentioned stigma. If we look back maybe 15, 20 years ago, having HIV and AIDS was considered a stigma. There was a taboo almost associated with it. But it feels as though we've come a long way. Does that show in the data and the research that's being done?
To some extent, yes. About 20 years ago, we didn't have good treatment. So we saw lots of people die.
Yeah.
And that was a big part of the stigma. I think also because the disease was first described in men who have sex with men, there was always almost a religious connotation, in line with punishment, or you must have done something wrong. And that, of course, led to a lot of stigma. Now that we know more about the disease and the transmission, stigma is definitely less, but it's not gone. So we have two kinds of stigma. The one is external stigma. So that is people discriminating against people with HIV. And in the recent data, we still see that about 10 to 12% of people will not buy fruit or vegetables from somebody if they knew that they were living with HIV.
Wow.
About 7% of people said that a child who's living with HIV should not be in school with other children. So those are clear signs that stigma is still there. And what we do see a lot in our patients is internalized stigma, that people feel that they've done something wrong, they feel that they're being punished. And that internalized stigma can make it really difficult for somebody to reach out for help, to go for treatment. So it's something we really need to talk about and to say, if you are sexually active, you have a risk of developing HIV. It is not something to be ashamed of. It's a treatable condition. And the more we talk about it, I think the better it will become.
I hear you on that. And what is being done in South Africa to curb the AIDS epidemic?
Yeah, so maybe if we look at the figures, I think that will help us to put it in perspective. So since the start of the pandemic, there have been about 85 million people infected, half of whom have died.
Wow.
So there are still currently about 40 million people living with HIV globally. And only in the last year, we've had an additional 1.3 million new infections. So that's about 3,500 new infections every day. And what is alarming is South Africa makes up about 12% of those new infections. So as a population, we make up less than 1% of the world population, but we make up 12% of new infections.
Wow.
So in sub-Saharan Africa, we know that we really have a big problem in terms of a high rate of new infections. We still see quite a few people dying of HIV, especially men, because they're quite reluctant to come to the clinic to be tested. So the mortality in men is higher than in women. So we have in South Africa about 8 million people living with the virus. We had in the last year about 150,000 new infections. So that's a lot. That's about, I think, 17 in an hour, for instance, to contextualize it. That's a lot of new infections. So prevention starts with knowing your status. That is the most important thing that you can do. And if you are positive, to start on antiretroviral therapy. We have excellent treatment available. It's 1 tablet a day. It suppresses the viral load. It's not a cure, can't take HIV away, but it can suppress HIV in the blood to a level where you can't transmit it to your partner any longer. So there's a slogan where we say undetectable equals 0. So that's really good news. If you can get your viral load down, you really cannot pose a risk to your sexual partners. So that is probably the most important thing that we can do. Secondly, we have pre-exposure prophylaxis. So that is either a tablet or nowadays an injection that one can take. It contains treatment for HIV, but it prevents the virus. So it comes into the system, but it blocks the virus from infecting the person. And we just had very good results earlier this year. There was a fantastic study that was done partly in South Africa, where they showed that a new injectable, it's given in the buttock, 1 every 6 months had no new infections in that group of women. So it's the first time that we've had such success. So there are big plans to get the medication available.
Sure.
And can you imagine just 2 injections a year, and that will keep our young women safe. Because it's an antiretroviral, one needs to take it repeatedly.
Correct.
You can't just take it once. It's not like a vaccine.
Correct.
Or, it has to be given every 6 months. There are also tablets available that one can take as a pre-exposure prophylaxis, but it means a tablet every day. And not everybody is so good at taking tablets, especially if they're not ill.
Yes.
So the injectable, we think, will be quite a game changer for
That's amazing.
for this.
So if we look at COVID, uh, we were able to create a vaccine quite quickly. Why is it so hard to create a vaccine for AIDS?
It's such a good question. So the way that the viruses divide is very different.
Sure.
So COVID, when it divides, it has a proof-checking mechanism. So when it makes copies of itself, they look almost exactly the same.
Sure.
And every now and again, there is a bit of a mistake. And that's why we saw these variants coming through, but really quite slowly. Every few months, you would have a new variant. With HIV, every time it divides, it makes at least one mistake. So it means that none of the viruses, if you are infected and you're not on treatment, not one of those viruses really look the same. They all look slightly different. And if you're not on treatment, your body can make up to 1 billion new viruses every day. So you can imagine the diversity in those viruses. So we've not been able to find a strategy that we can immunize somebody with a piece of the virus that is stable enough to train the immune system to recognize HIV when it comes through.
And maybe further to that point, could you explain the difference between the injectable and the vaccine that you've just mentioned?
Yeah, there's a lot of confusion about that. So a vaccine is a way to train your immune system. So we give a small portion of the virus that's inactivated, it can't replicate, but it's enough for your immune system to see it and to make antibodies against it. So antibodies are like the soldiers of the immune system almost. They go and sit in the mucosa, and when that virus comes in, it will block it. It will attach to it. It will eliminate it. And that's the goal of vaccination, is to have these soldiers all throughout the body. And that immunity usually lasts very long. We're looking at 10 years, maybe even a lifetime for some of the vaccines. The injectable is just a treatment. It is a one medication. So when we treat HIV, we normally use a combination of drugs, but this is just a single drug. So it just prevents the HIV that comes in, but it doesn't stay in the system, and it doesn't do anything to your immune system to train it and to make it, recognize the virus when it sees it.
So are there any other groups in society that are developing that are at risk at catching HIV and AIDS?
Yeah, it's quite interesting. So over the last couple of decades, we've seen that divorce has almost become normalized in the society. And it's usually the older age groups. So we're looking at people in their 40s or 50s. And we've seen a rapid increase in sexually transmitted infections in those populations. Mostly because I think when they were younger, they didn't have to use condoms. They didn't have all of that training in how to prevent STIs. And now that they're older, they're in a new relationship, maybe they don't have the vocabulary, maybe they don't know how to approach the subject. So we have seen that they are also vulnerable to becoming infected with HIV. So I think one shouldn't think in terms of key populations only. One should think anybody who is sexually active potentially has a risk. And it's your responsibility to make sure that you are safe, and your partner's responsibility to make sure that they are safe. And it starts with a conversation of, do you know what your status is? When last did you test? Have you tested for other STIs? And that's a sign of a mature relationship. And I think something that we should encourage, talking about sexual health, getting rid of all the taboos.
Breaking that stigma, actually.
Exactly. And especially for alternative type of behavior, whether it is men who have sex with men or sex workers, we need to normalize that conversation. Otherwise, we will never get rid of this pandemic or this epidemic in our society.
So thank you, Professor, for your time, but also just giving us some great insights into the AIDS epidemic in South Africa.
Thank you for giving me the opportunity to talk about this disease. I think it's such an important thing to do. So thank you to you.
It's a pleasure. Don't forget to subscribe so you don't miss out on any of these insightful discussions we're having. See you next time on The Wellness Effect. BankMed. the medical scheme of choice for the financial services industry. The Wellness Effect is proudly brought to you by BankMed, yours in good health.